and I'm pleased to talk to you my concepts of benign prostatic obstruction. BPO is a better word to use than BPH. This is a landscape where it's a changing paradigm, at least in the Western countries, but there are some standards that work around the world. And what I would like to do is to carry you through some concept combining the guidelines of the American Urology Association and my experience with the various devices that we have tried at Wake Forest. Why isn't this moving today? So in the good old times, during my residency training, certainly, life was very good. Every man that, at least an older man that came with any urinary symptoms, we blamed the prostate and we took it out. And in fact, in those days, you got paid pretty well. It's subsequently separated between the so-called irritative and obstructive symptoms. We learned through a physical exam size of the prostate, and these days hardly anybody does a rectal exam. We rely on ultrasound and other imaging to rely on the prostate. The need for serum creatinine, et cetera, has declined. Nobody does IVPs anymore. Cystoscopy, although done routinely by urologists around the world, has been clearly shown not to be indicative of obstruction, although the size and shape of the prostate can be. We then did the surgery, and there was a simple choice between a monopolar TURP or an open prostate. Well, over the problem, we've learned that a male lower urinary tract symptoms has multiple overlying circles. It could be due to the prostate enlargement. It has been clearly shown that overactive bladder can be idiopathic and or due to other bladder conditions, can be a reason for the symptoms. And then simply taking nocturia, you will see that that's a completely different condition. The famous EpiLUT study done showed that if you took men over 40 years of age, and this was a study in over 14,000 people, about 71% of them complained of lower urinary tract symptoms. And what you need to separate out is symptoms during urination, which is stream, hesitancy, etc., or storage symptoms, which is the frequency and urgency. But also important is post-micturition symptom, and post-void dribble would be the most common among them. And particularly in situations where people have to squat and wash, and as they get up, if there's a dribble of urine, you obviously have to wash again before you go into the mosque. So that becomes very, very important in terms of symptom bother. Post-micturition dribble has very little to do with the prostate and or bladder. It is the habit, the way you urinate, and by the pushing that causes storage of a small amount of urine just above the sphincter, causing the post-void dribble to happen. Regardless, voiding symptoms were a smaller percentage, but an overlap of storage and voiding was a bigger group. But there's, as you can see, there is a significant portion which is post-micturition symptoms alone, which does not require medication, does not require surgery. It requires re-education of the patient in terms of improving their symptomatology. But in a circle of lower urinary tract symptoms, you can see there are multiple players which can cause these symptoms. And the label of prostatitis, which is often used in young males, it's been proven to show it's more pelvic floor dysfunction, nothing to do with the prostate. And one trick to assess this so-called prostatitis is to do a PSA test when they have the symptoms, and it'll be very low, thus suggesting it has nothing to do with the prostate, and it is more to do with pelvic floor behavior. The regular players of detrusor overactivity, the prostate obstruction, and the nocturnal polyuria is something that we deal with most of the time. Detrusor underactivity is also poorly realized because the symptom presentation is often mimics detrusor overactivity, which is frequency urgency, and they learn to compensate by pushing, which leads to the post-void dribble and the pelvic floor dysfunction. So this is a condition we have not won as yet because we don't have a good solution for the detrusor underactivity. Patients with neurogenic bladder dysfunction with an overt neurological condition, you obviously need to work up differently. I want to spend a minute or two about nocturnal polyuria because nocturia is the most bothersome symptom. And since it disturbs sleep, makes the patient sleepy rest of the day, etc. In a short description, I would say that it is rarely due to a urological cause. Most often, it is a non-urological cause, and it is related to a larger urine output at night. It could be renal in origin, such as untreated diabetes mellitus or insipidus. You can have a cardiac situation which causes peripheral pooling. You have sleep apnea, which can cause increased urine output at night. Primarily drinking a lot of fluid late into the night, use of diuretics late into the night. Any older person who's hardly moving with the leg dependency stores a lot of fluid in the lower extremity, which gets mobilized when you lie down, and that causes urine output. Simply measuring the urine output at night gives you a good idea that this is volume-induced nocturia, and that can be best managed with fluid management and other measures rather than treating the prostate. Most importantly, the subjective symptoms are best measured with a validated symptom score, and perhaps the most used is the AUA symptom score, or also known as IPSS. Associated, if you evaluate the erectile dysfunction with SHIM or IIEF, this is a routine we follow at our clinic because there is significant association of erectile dysfunction and prostate symptoms, and both can be assessed by getting a baseline score with which you can compare in the future. What's important to learn is what is the purpose of the symptom score. The symptom score is best used for patient screening, not necessarily for diagnostic. It can be helpful in outcome comparing before and after, and it has certain research criteria. Based on the MTOP study, a change in IPSS required by 4, decline by 4, the number would be considered meaningful treatment. It was developed by Barry et al. In '92. It became very popular today. It's been translated in over 40 languages and used around the world. So what are the principal causes of male urinary tract symptoms? I would say majority would be outlet obstruction and or detrusor overactivity. But as I mentioned earlier, underactivity can also cause these symptoms. Non-urological causes is fluid problems, mainly manifested by nocturnal polyuria, and there are a whole host of other conditions, mainly psychological. Whenever you have anxiety, it has been shown that you have increased urinary frequency. So person urinating very frequently during the day and sleeping through the night would lead me to believe that this person's problem is sensory in nature. Excess fluid intake would be also daytime frequency, and there are multiple causes of sleep disturbances which can cause nocturia. Is there a diagnostic symptom of prostatic obstruction? Unfortunately not. There is no significant or sustained symptom that can tell you this person has prostatic obstruction. There's a compilation of symptoms which can help you, but not diagnose for you. So the best way is to assess, correcting a symptom score, and then we evaluate by their flow rate, by their residual as a screening tool, and depending on their history, if they have a metabolic disorder such as diabetes and or any neurological condition, then you're advised to do a urodynamic evaluation. The imaging features of trabeculations are associated with detrusor overactivity, as it's seen in children and women, and not in men alone. Prostate size has weak association with obstruction. However, today, based on the treatment parameters you choose, size and shape may matter depending on the type of treatment you're going to devise. If I'm going to do a TURP or a suprapubic prostate based on the size, then it doesn't matter the shape of it. But if there's a big median lobe, today UroLift would not be an ideal choice for that person. So definition and terminology is very helpful. Benign prostatic hyperplasia, or BPH, is the most commonly used word, but it's a histological diagnosis. We should talk about benign prostatic enlargement, which occurs in all men over the age of 40. In some, it becomes symptomatic to result in benign prostatic obstruction. And then those 5 out of those 100 will have outlet obstruction, or BOO. The guidelines which are available from the AUA are very helpful to give you a paradigm from where the symptoms are, where the recommended tests, these are available. And also for your patients who use the web, it's best to use something called Urology Health, HEALTH, urologyhealth.org. This is a patient website from the American Urology Association and the Urology Care Foundation, which is very helpful to the patients for a variety of conditions. And you can use that to give instructions to the patient how to manage conditions. And it's a very, very good website to learn. It's also available in multiple languages, so that it's helpful if there are a locally accepted language that can be done. So this is a guideline which sort of goes through the algorithm that I just talked about. So simplifying it, the medical therapy algorithm, you have a patient who has a symptom score of 7 or less without bother. Prostate is small, there is no treatment needed. This is a screen, and depending on the age, you would do a PSA or not. If the IPSS is more than 7, again, if patient is not bothered and or does not have significant residual, then again, no treatment is needed. So if I get up 4 times at night and I'm not bothered, I go right back to sleep, I don't necessarily need to be treated. But if you are someone who's bothered by getting up once at night or twice at night, I need to treat you if you're bothered by it. So alternative medicine, which is highly used in terms of phytotherapy or other agents, at least at this point, there is no meaningful effect. My line to the patients, it does you no harm because it doesn't alter the PSA. And if they wish to take it, subjectively feel better, I don't object to it, but I certainly don't prescribe it. So now if you have a IPSS of less than 7, but the prostate is large and or PSA is high due to volume, you need to assess the PSA based on the density. However, good evidence that 5-alpha reductase inhibitor is a prevention drug that can prevent future retention based on the MTOP data. If you have patient who has more than symptom score of 7 and is moderate to severe bother, the prostate is small, I would use an alpha adrenergic blocker alone, not with the Proscar or finasteride, because there's no role for under 40 grams of prostate of using finasteride. If you have, again, a patient who has significant urgency associated with this, a combination of alpha blocker and anticholinergic can be used because it's safe to use anticholinergic based on a variety of studies, although the labeling says not to use it. If the prostate size is large, then a combination of alpha blocker and 5-alpha reductase can be used in good measure. The patients, if they have large size prostate, use of other agents such as the use of PDE5 inhibitors has also been used. Of course, this is a very expensive way to treat the benign prostate. So we come down to the therapeutic option. We've talked about the non-invasive option of watchful waiting or medical therapy. If we now go towards invasive therapy, most men don't like to take drugs. They would like a treatment. However, they would like a treatment that doesn't affect their sexual function and or ejaculation. That becomes a big problem. And then you have to decide, if you're going to do an invasive test, is it important to do some urodynamic evaluation, ultrasonography, or cystoscopy? And then there is the option of minimally invasive surgery or ablative therapy, which I call surgical physical removal of portion of the prostate. So it largely depends on quality of life and avoiding symptoms. When you have retention, there's very little to discuss. However, evaluation of their drugs is very important in lower urinary tract symptomatology. So if we now come to alternatives to treat benign prostatic obstruction, what about new technology? Should we adapt to it or wait till it's proven before we get on the bandwagon of treating new? So what are the considerations when you're treating or considering a patient for prostate surgery? Are there indications? We've talked about that already. What about the patient's medical condition in terms of health, ability to tolerate anesthesia? Surgeon is important based on your experience. What are you used to? What are you good at? Is what you should be doing, rather than trying something new that is unproven at this point. And of course, affordability is very important in most parts of the world where insurance, et cetera, is not covering the cost. And is the device easily available to you in terms of treatment? The indications primarily should be outflow obstruction, retention due to obstruction, lower urinary tract symptoms that are bothersome, overactive bladder that is secondary to obstruction, and which is a urodynamic diagnosis. Nocturia can be due to BPO, but as I mentioned to you, majority of the time it's not. Just male patient with the prostate is not an indication for surgery. In terms of the patient, medical risk for anesthesia is important. What's most relevant today in our choice of treatment is if they are on antiplatelets or anticoagulation. Fully 50% of our patient population these days is on antiplatelets for coronary disease and other atrial fibrillation or some other reason. And you need to manage the condition around it, because with drug-eluting stents, et cetera, they can't stop their platelets. So treatment choice then becomes important, how you're going to treat the patient. The gland size matters because it's simply no choice between TURP and open, because there are many other treatments available. Gland anatomy matters because median lobe cannot be treated by many different modalities. And the most important in young patient is the desire to maintain antegrade ejaculation in giving up long-term therapy. That means there are devices available which don't have long-term results, but wish to use because of the ejaculation. The catheter duration is also very important. It's the most bothersome postoperative effect of a prostate surgery. So the less the catheter used, the better it is from the patient's point of view. So the patient looks at how the treatment is affecting my quality of life, whereas we have hung around the objective parameters of how good the flow is, how reduced the residual is, how much the gland are removed. That's not very important to the patient, but it's important to us in terms of maintaining. What's relevant is the immediate post-op side effect of burning, frequency, and urgency, which occurs with a lot of different treatment that cause vaporization. Surgeons' training and familiarity with the technique, number of patients that you're treating per month. So if you're going to learn a new technique, you need to have a learning curve. Learning curve takes several cases. And if you're going to do an occasional prostate surgery, then it'll take you several years to get better at that treatment. If it's your desire to be the first one to use that treatment, then you need to invest in learning before you go on to that treatment. Are you able to deal with transient problems that occur postoperatively? If you're the only one in your office and your clinic treating, you have no support system in terms of good nurses and or assistants who are going to feel the questions after treatment, then it's a problem for the patient that they can't reach you. Secondary bleeding, et cetera, is a big problem with some of the treatments that require repeat treatments. Affordability, there is the US and the West versus low or in middle income countries, where the cost of the capital cost of the device or disposables is a very big factor. In the West, most patients are insured versus out-of-pocket expense for the rest of the world. Hospitalization is very expensive in the US, but it's not a factor, at least in India, where I come from. So it doesn't matter how many days you stay in the hospital. That's not the cost. The cost is of the device itself. And what is the capital cost of the device versus the disposable is an important factor. The availability, initially, most of my trials are based on clinical trials, which is supported by the company. That's how I use the new device. We are known for a center of excellence for prostate treatment. So most companies would come to us at Wake Forest for trial, and at the VA, where I have a large number of male patients to conduct a trial at a rapid pace. You need to have a hospital partner that allows you to do those trials. And of course, you need a good referral base. TURP monopolar is a forgotten science in the US. I asked my residents yesterday about some questions, basic question regarding monopolar. Zero knowledge. They've never seen a monopolar prostate. So they have completely forgotten the conditions that we used to deal with all the time in terms of the TUR syndrome, the absorption of fluid, the possible electric burns that can occur, and that is a problem. Today, saline is the commonest used irrigant because both for the laser and bipolar energy, we use saline, but of course for monopolar, that's not good enough. Water and or glycine is used. Water is very cheap, but it can cause intraoperative problems of absorption. And certainly saline resection is much more safer to use, but you must have the appropriate device. I think if you're using a monopolar device, it's important to use a timer and time your resection so that you communicate with the team and monitor anesthesia-wise in terms of the signs, early signs of TUR syndrome, of absorption, and of course, maintain serum electrolytes after the surgery. It's important to avoid these complications. These TUR syndrome is characterized by bradycardia, hypertension, mental confusion. If the patient under spinal, it's helpful because they manifest these symptoms early. If they're under general anesthesia, you only find out after, where the sodium will be so low that can cause a rare case, but yes, death has been reported from the hyponatremia. So the absorption is due to the sinuses that are open early in the resection and the fluid that's being absorbed. If you get into the sinus very early in your resection, then of course, this is a much higher risk. Prevention is the most important treatment, and getting rid of the excess fluid by giving Lasix during the case, stopping your surgery in time is the most important. Using low pressure for irrigation is helpful, and using, of course, continuous flow resectoscope lowers the pressure in the system so you absorb less. The advent of newer technology, the bipolar, changed the way we treated. Time was no longer a factor, so size became less of a factor. I can resect as long as I want, as long as I don't fluid overload the patient. It is safer. You don't need the ground pad, so burns are not in effect. And of course, you have reduced thermal energy. The bipolar has a better coagulation effect because it moves slower through the system, and it's certainly improved in that regard. Surgical decision in terms of appropriateness of the device, we've sort of gone over these factors. The cost is a factor. So there is a whole host of new treatments, from bipolar to green light to robotic-assisted simple prostates. You have the thulium laser, which is very effective, very exceedingly good to cut at, whereas the less invasive is the UroLift. You have the aquablation. The HoLEP is the most studied device, and the steam therapy or Razum is one. I've not put in the newest Olympus device, the iTind, on this particular slide because it's too new as yet. We looked at 4 different modalities in our system to look at cost-benefit ratio, comparing simple prostate to robotic to green light and the bipolar. And in looking at the cost particularly, we looked at 24-month period from 2012 to 2014. We had 232 patients that underwent treatment, and majority were bipolar, more than 50%. Robotic surgery were 43, and the green light were 62. Small number of patients had open simple prostate. It's a rare case for us to do that. And we compared the total charges. As you can see, the robotic prostate is the most expensive, and of course required the longer hospitalization was for the open prostate, and the cheapest were the TURP and the green light. No significant difference between the two. The green light cost a little more in terms of the device. No difference in terms of the recovery and or objective parameters. So in comparison, I think if you look at the charge versus the efficacy, the endoscopic treatment, the TURP with the bipolar and or green light were cost efficient and the greatest value. Of course, it depends on the size of the prostate, and so you need more effort. With the bipolar and or the green light, as well as thulium, you can do enucleation if you have the prostate that's large, but that requires a higher learning curve. So we also were involved in a newest device, that's the aqua ablation, which is the water study. This is a device that is independent. It's largely ultrasound based, that you need to do some surgical planning, and the robot essentially executes. So as you can see, we are introducing the device here in the film, and the prostate is being seen on the ultrasound, and the scope is here, it's lined up, and then we measure the prostate in both the transverse and sagittal fashion. Here's the bladder, this is the prostate, some median lobe here, and we align the prostate accordingly, and then based on that, we would treat the prostate. As you can see, the device can be seen visually here, and here on the ultrasound, it's the water pressure is moving or removing most of the prostate. It takes, as you can see on the timer, takes 3 to 4 minutes to complete the entire procedure. However, the setup time can be as long as 20 to 30 minutes before you're ready to use the treatment. But then you don't have to clean up after, except irrigate, so you don't have to remove the chips or anything like that. So overall, in a comparison study with TURP, it was more efficient. It maintained the ejaculation better because it removes the prostate in a wing fashion around the verumontanum, preserving the verumontanum. So antegrade ejaculation was better in that regard. So the aqua ablation, as you can see, has a motorized device, and we compared to large prostate. This is mean prostate volume being 107. Open simple prostates, we compared it to others. The transfusion rate is present in large prostate, but it's much lower than simple prostates. And of course, the hospitalization is much less compared to an open prostate. Of course, the device cost is there compared to an open prostate, which is cheaper. So we looked at our own recent experience. This is at the Veterans Administration. This is sort of a 4 or 5 month experience from July 22nd to the November. We had 12 open simple prostates. Average weight was 110 grams, and average surgery time. This is obviously being done with the residents. Blood loss and transfusion rate 33%, which is a significant factor. And there are ways to decrease the bleeding during a prostate, basically bladder neck advancement, plication inside the prostatic fossa, first-string suture around the neck to reduce the bleeding, but you have to have a good vision. Of course, packing works for everybody. So it comes down to what is best in patients, what is your learning curve, what is the key point in the technique that you need to learn. You look at short-term and long-term outcomes before you go to change from a monopolar to some other treatment. So my questions now to you is, what do you commonly use? Are you still on monopolar? Have you switched to bipolar? How much of the prostate is removed as an open procedure in your practice? I hope somebody's there with me. Hello?
Hello, hello. Can you hear me?
Yes, now I hear you. Were you able to hear me?
Yeah, I heard you. I kind of lost you for only like 1 minute or something.
Okay, so I thought if you have some questions and or I wish to learn, what are you doing there in terms of your practice, and anything
Okay.
that I could answer.
Thank you, Dr. Badlani. It was a nice presentation. We're very happy that you had the time to have discussion with us. In our setup, we are, unfortunately, we don't have the facility to do a pressure flow study on all patients. So we mostly depend on evaluation of the patients based on clinical data only. And we have access to monopolar QRP. So we usually routinely do monopolar QRP for the smaller prostates when they're usually like below 70 or something. And if it's anything above that, we usually go for open simple prostatectomy. And our challenge is actually on which way to actually progress, because we've been doing monopolar PRP for a few years, for quite a long time actually. So we just wanted to know what the options we had were available for the bigger prostate. And you actually described it very well, and I'm glad that my residents are also listening to what is available in the rest of the world, even if we may not have access to it. So my question was, what is your experience with enucleation with bipolar, for example, bipolar enucleation?
So yes, I have used that, and of course, there's a Chinese colleague, Dr. Li Pingji, who's really the world's expert on that, I think. But it's possible. You need to use a combination of the button and the resection. That's what I do. I start the enucleation with a button electrode from the apex of the prostate and enucleate towards the bladder neck as much as I can, and then switch to the loop and resect, which causes less bleeding and the feasibility of doing a large gland in a reasonable time. And you don't need to use a morcellator, because with the holmium or the lasers, you can enucleate, but then you need a separate device to morcellate the prostate. With the bipolar, going from button to a loop, you can resect. I think outside of this country, I reuse the loop a lot. I travel on mission trips to a variety of parts of the world. So monopolar certainly is the cheapest way to treat, because the monopolar loop can be used till it breaks. The bipolar loop, I've not had experience in multiple uses of it, but certainly there is a Indian version of it that can be reused a lot. So I would, if I'm going to switch, I'm going to switch to bipolar as one device, which would fit a large percentage of cases. The saline cost you have to look at compared to the water. But if that's possible, then I would highly recommend bipolar as the cheapest way to deal and make the patient safer in terms of learning the device. All the disposables and or devices are too expensive, and their long-term survival is not good. So if you have 5 patients in your area who can afford it, well, send them out to go get it in Europe or somewhere else, because if they are able to afford the device, they can afford to travel. So it's better to do that, or because it's just not cost effective to do that, in my opinion.
Okay, thank you. One more thing is, what's now the pathophysiology of retrograde ejaculation has changed. In the past, when we were learning, it was considered that the internal sphincter was the reason why the patients had retrograde ejaculation, but now preserving the tissue around the veru has been said to be the reason why patients tend to have antegrade ejaculation. So what's your experience with that? How do you counsel your patients?
Well, counsel my patient in terms of, if you want to preserve ejaculation, then you have to use the UroLift device and or iTind, which is from Olympus, or some laser devices that just make the incision. But most ablative therapies, including aquablation, I don't guarantee them they'll ejaculate. They have a better chance of preserving ejaculation because aquablation leaves more tissue in front of the veru. I've not consciously tried to do that in bipolar resection. It's something worth trying in the future. But I think, they have to realize they lose a significant volume of the ejaculate because the prostate is ablated. So they don't have the volume of the prostate to produce the ejaculate. Yes, there is a seminal vesicle and some prostate still there, and urethral secretions come out, but I don't promise them anything in terms, except for UroLift and iTind, that their ejaculation will be preserved.
Okay, thank you. Are there any questions from the participants? I think some of them are texting on the chat. We can see that.
Let's see. I'm less tech savvy than you guys. I don't see any tech chat questions. We are using monopolar is what the chat says. So I grew up on monopolar. That's what I used most of my life. I still use it when I'm traveling. Certainly, most comfortable with the bipolar. I think if you're going to switch or you're going to invest in, bipolar is the best way to go. The thing is,
we have one question. It says, what's your experience with tackling with patients coming with bleeding BPH? Sometimes we see in our setup patients who have kind of neglected their symptoms. They come with significant hematuria, sometimes to a point where it causes anemia, and we have to treat them in as an emergency. So
yeah, so
you guys do
one obviously you're going to place a catheter and decompress the patient. Sometimes decompression itself causes bleeding because if they've been in large retention. So acutely you have to manage. Prostatic bleeding can be helped by use of finasteride because it has the anxiolytic effect. So within a few days, you can reduce the amount of bleeding from the prostate due to Proscar or finasteride. So that's helpful. It has also been tried preoperatively a week or two before to reduce bleeding during surgery. So that would be one measure to use. Otherwise, temporarily placing a suprapubic tube to decompress, especially if the patient has come with a very large retention where you might not succeed in terms of urination even after surgery, my technique would be to not only deal with the prostate, but leave them with a suprapubic tube that can be used to measure their post-void residual and or be used as a treatment after surgery. We place the suprapubic tube percutaneously or using the Loesley retractor. Loesley retractor allows you to bring the retractor to the skin and grab a large Foley catheter without making an incision. And then you deal with the prostate and leave the suprapubic tube in addition to your urethral catheter. And once you're ready to take your urethral catheter, the suprapubic is used as a measure to see what their post-void residual is.
Okay. So we have one question from our resident. He's asking, does leaving some tissue around the prostatic apex help in maintaining ejaculation?
I don't know of a study, except in the aquablation data group where there was comparison trial to a TURP. There is no such experience to talk about ejaculation improving by leaving tissue in front of the vero. I don't know of a scientific data. Of course, in the aquablation, it was a questionnaire-based answer that they did better than TURP in terms of ejaculation. It's not that all of them maintained ejaculation. And it's a big psychological discussion with the patients about ejaculation. And you need to be able to preoperatively separate in the patient's mind erectile function, orgasmic function, and ejaculation. Once you explain that orgasmic function is maintained, erection is unchanged based on your treatment, that yes, your ability to have a child would be reduced, then most of the patients who are in their 60s and 70s will say, well, that doesn't matter. But they don't necessarily understand that ejaculation is separate from orgasm. They assume that they will lose their ability to achieve that sensation, and that's why they're bothered. If you separate out the three, the erection, the ejaculation, and orgasm for them, majority of my patients, they end up saying, well, that doesn't matter to me, because they already have that effect using Flomax. Majority of them are on alpha blockers and they don't ejaculate. So it becomes like they assume that they're going to lose their erection or orgasm. But you ask them, are you ejaculating now? They say no. So then what's the difference?
Okay. I think we don't have any other questions.
My pleasure to be with you guys. Hopefully we meet face to face at some point. And one day, maybe, inshallah, I'll be there in Ethiopia.
Yes. Thank you, Dr. Badlani, for being with us.
Bye-bye.
We hope to see you
And
soon.
Katie, thank you for putting this together.
Yeah, thank you so much, Dr. Badlani. And thank you also, Dr. Lemma.
Okay, let me know in the future if we can help. I have a lot of colleagues here, whether they are part of IV or not. I have many, many colleagues here in terms of cancer experts and others. If you need particular talks, I can arrange for them to give you the talk. Okay?
Okay, thank you so much.
Yeah.
Okay, thank you so much.
Bye-bye.
Bye-bye.